answer your questions regarding the video I released this week, other ADHD topics, or mental health in general. I'm noticing that I'm getting weak connection signals. So I am traveling right now. My kids just graduated from college, so I was trying to get to both of their graduations. So if there are problems with either the voice or the sound, I hope you'll let me know. And two other things. The comments I say here are for general information practices, so I'm not prescribing for any of you. I can't make specific recommendations since I don't have a doctor-patient relationship. Two, there's also a subreddit forum at drjohnkruse.com. So that may be a better way for some people than the YouTube comment section, but you're welcome to add follow-up questions there. And without further ado, I'll briefly summarize in a minute or so. The only video I released this week was an older video on perfectionism and ADHD, which I had re-recorded and re-released. And on the surface, ADHD and perfectionism may seem antithetical in that ADHD, one of the cardinal 18 symptoms, is making frequent mistakes because of inattention, also social errors from blurting things out, intruding on other people's spaces, being hyperactive, problems with tardiness, problems with the emotional regulation, all can lead to imperfect behavior. And yet, at least in one survey of individuals with adults with ADHD, the most frequent problem, cognitive distortion leading to problems, was perfectionism. In that case, specifically, it was needing everything to be just right before you start a project. And although there's some genetic contribution to perfectionism, certainly a lot of it is learned. It seems to be particularly more prone in individuals who grew up with overly critical parents, adults, teachers, coaches, others in their lives. And there are a number of cognitive and behavioral approaches to learning to be less perfectionistic. And one of the first steps is, rather than saying, I am a perfectionist, or making it part of your identity, making it part of the list of behaviors you currently employ. And behaviors are easier to change than personalities. So if there's questions or further discussion on that, I'm happy to get into it. And I do see Dennis has some questions, so I'll try to answer them. Hi, Dennis. And I'm going to need to put glasses on because I'm working from the laptop. So Dr. Joanna Moncrieff is a British psychiatrist who said that psychoactive substances create rather than reverse abnormal brain states. Do you agree? And he's adding the context. She said that alcohol helps reduce social anxiety, not because it corrects an underlying chemical imbalance, but because features of alcohol intoxication include relaxation and disinhibition. So some of this is semantics, some of this is emphasis, some of this is overt distortion of bodies of scientific information. So Dr. Moncrieff is one of the leaders, and she makes much of her living by promoting the idea that serotonin reuptake inhibitors do damage, they don't do anything good. So these weak drugs, which can't do anything positive or good to help people's brains, are horrible, bad, because they're strong and do damage to people's brains. That on the surface doesn't even make much logic, but her stance is along those lines. So some of it, again, becomes semantic in terms of what's abnormal or normal. So in this situation, or the example Dennis is bringing up, she has to be defining social anxiety as not as a normal brain state, and that it's being disrupted by alcohol. I think whether you want to call it a disease or something else, most people don't have social anxiety to the extent that it it significantly impairs social interactions. So I think it is fair to call social anxiety, where it's so severe that it's causing distress and causing dysfunction on an ongoing basis, as a abnormality. And given that our feelings, our actions, our thoughts are generated by our brain, I would argue that it's a tautology almost, but it's a necessity that there is an abnormal underlying brain state if you have an abnormal behavior, if you have an abnormal set of thoughts, or if you have an abnormal set of feelings. So to me, it doesn't add a lot, but to deny that it has anything to do with an underlying brain just seem, I mean, where does she think, or others who make this claim think these are coming from? Is it our spleen? Is it our hangnails? Is it? So I just don't agree with her stance. I think she's distorted and misrepresented information. She certainly cherry-picked data. I mean, one of the things for serotonin syndrome, they solicit online people of, have you had specific problems withdrawing from serotonin reuptake inhibitors? And then they publish the data that they get with a very select population, with pretending that that's somehow representative of all people who've taken serotonin reuptake inhibitors. That's just misleading to the point of dishonesty, and gives you an exaggerated rate of problems from withdrawing from serotonin reuptake inhibitors. I'm not saying nobody has had problems. Many people do, but tapering off of them don't. So no, I don't. To me, it doesn't make any sense to claim that the only things, substances we're putting in our body, are only causing abnormal. I mean, you could argue that it's different. Well, I don't know what. I don't know that it's worth getting more into that. But I'm welcome. If people want me to, I can talk more in depth about that, or what our drugs do or don't do. I mean, she's correct if she says nobody knows the exact step-by-step mechanism by which any of our psychiatric drugs resolve an underlying brain state. That, I would say, is true. So Max is bringing us back to the perfectionistic video, and he says, assuming people are more perfectionistic when pursuing activities they enjoy and are actively engaged in, wouldn't that inherently link it with ADHD because of being more interest-driven? So one is, I'm not sure that the underlying assumption is good, or valid. I mean, it's reasonable, but I'm not sure how. I think people with OCD, PD, so obsessive compulsive personality disorder, is maybe our best match for perfectionism, that it's defined as a pervasive state of trying to have everything controlled, trying to be things in aligned. And I'm not sure that it's more prominent on tasks the person enjoys. I think actually it's at least as likely in the tasks that they have some amount of insecurity about, which may be the ones they don't enjoy, and the ones they think they aren't going to do as well in, that they feel even more of a need to micromanage, try to do jobs that are so good that there's no flaws in it. So again, whether perfectionism is actually interest-driven rather than importance-driven, as ADHD is described as being interest-driven rather than importance-driven, I'm not sure we have much data, and my clinical impression would be that perfectionism isn't particularly interest-driven. So Goosebumps says, thanks me for making the videos. You're welcome. I hope they're useful, and I hope the question and answers are useful. So Max is also forwarding a comment on the Reddit channel by Substantial Bunch. So this individual used to watch a lot of boxing, mixed martial arts and others, but now feels that these should be banned. It's just glorified brain damage. Any thoughts on the mental health impact? So it's interesting that in the last, and I don't even know how far back now, starting about a decade ago, and it was largely the work of a single pathologist who brought to attention the damage football playing causes to concussions. There have been others who've been doing work over the years. And so much of the recent interest has been focused on football and whether kids should be playing it at all. There have been a handful of prominent NFL stars who've retired when maybe in a different era they would have kept playing and potentially incurring more damage. So the general public is now quite aware that being hit on the head can, again, and this is a can, so it doesn't mean everyone who's had a concussion winds up with brain damage, but there is a characteristic pattern of brain damage that correlates with the number of hits times someone's been concussed, that this can happen even without loss of consciousness, that probably the magnitude of hits also has some correlation. But again, there are some individuals whose brains, for different reasons, or their bodies are more resilient. I should add that there's good data that damage to the brain can happen just from a body slam. So we have so much emphasis on wearing helmets, but you can be concussed to the point of being knocked out just by having your body slammed, because that does shake your head around, and the likelihood of a helmet helping with that is negligible. Some other things we know about brain damage from head. So some of the interesting things I can remember, and I was born in the early 60s, seeing a tiny, and I have not been able to track this down, but somewhere junior high school years when I was a swimmer, and I had friends who were soccer players and wrestlers and other sports, but there was a little article, it was from a European research group where soccer, or football as they call it, so to distinguish, we're talking about soccer here, European football, showing just that high school, college soccer players on average had IQ scores. It was just 2 or 3 points. It was small, but it was measurable. And the assumption at that time was that it was from heading the ball and repeated damage to the brain over time from doing that. So in the US, there's so much emphasis on American football players, and yet we've known, soccer and others who use their head. And there's also a Parkinsonian-like state. I think it's something pugilistic, or pugilist as a fighter. So we've known that people who are boxing and presumably other mixed martial arts, we've known for decades, that can also cause a pattern of brain damage, traumatic brain injury, or encephalopathy, CT, chronic traumatic encephalopathy. So yes, what I'd say is we should be aware of the risks of these endeavors. I mean, a couple other things I'd point out, though. There's no endeavor people engage in that is completely devoid of risks. Some are clearly much more risky than others. Driving wearing a seatbelt is safer than driving without a seatbelt. It's substantially safer, despite some people still claiming it's not. It is, but do people still get injured and or killed who are wearing seatbelts? Are there even a few instances where a seatbelt may contribute to death because someone couldn't escape as readily? Yes, but again, the data is overall substantial risk reduction by wearing a seatbelt. Whether governments should be intervening in vocational activities or avocation, hobbies or interests where people are voluntarily engaging in mixed martial arts or boxing or football, I'm more comfortable with mandating helmets for bike riding and motorcyclists than I am for banning boxing or even football. I mean, I think socially we should discourage it and it should be shunned, but whether a government should ban it is a separate political question, and probably I probably should not be going too deeply into the political issues, but should be clarifying where the borderline and interaction between mental health and politics are. So Max is also forwarding another Reddit comment from Significant Club, who asks whether the autism spectrum could be broken down into different diagnoses, and thinking that would be a good idea. And it's pretty clear, and I'd say I probably have less information about autism than depression or what we call schizophrenia. Pretty clearly, most of our major mental health conditions are a collection of different conditions if we're basing the ultimate origins or etiologies or what caused them to happen. Or we can talk about ADHD. ADHD has a strong genetic component. There's certainly some individuals with one or both parents and all their siblings have it. And yet there are others, some of them kids with no family history, but maybe high levels of lead exposure in youth, or fetal alcohol syndrome, or traumatic brain injury. And if it happens early in life and they develop their ADHD symptoms before the age of 5, we call that or treat that just normal neurodevelopmental ADHD. On the other hand, if that happens when you're 25 or 30 with no previous ADD symptoms, they either declare it secondary ADHD or say, no, we don't even call it ADHD. So I think it will turn out to be likely that autism is multiple conditions or come from multiple origins. I think we're moving towards, if functionally the same set of pathways or circuitry is impaired, then I could argue does make sense to maintain some label. And again, for ADHD, I think it's primarily prefrontal cortical executive functions. So regardless of how you damage them, I think that is where we're moving towards diagnostically. But in terms of autism, I simply don't know enough about distinctive subtypes or what would make sense in terms of breaking it up or defining it and splitting it rather than lumping it all together. So Silencer asked, how is ADHD linked with perfectionism? And this individual feels like a lot of things they do have to be perfect. So the video I can summarize, and Max kindly provided the link to it there. So one is, we know, again, both ADHD and perfectionism have genetic components to them. And as with almost everything we're finding in the mental health realm, it's not just one simple dopamine receptor problem, gene for that leads to the genetic component. It's the impact of which variant you get on hundreds, if not a few thousand different genes. And interestingly, many of these genes that are having a tiny impact are similarly increase your risk a tiny bit for depression or ADHD or any. So they seem to be more general mental health maladies increasing the risk. So one is, there's almost certainly some shared genetic heritage for perfectionism and ADHD. I should point out that the genetic component to ADHD is substantially stronger. The H heritability is about 0.8, whereas for perfectionism, it's much lower. And interestingly, at least one study found that self-directed perfectionism, so that's you are holding yourself to a higher standard versus societally driven or perceived perfectionism, where you're doing it because you perceive others think that this is what's perfect and you have to match that. So I would have guessed ahead of time that the innately was more genetically driven, but it's actually the opposite way around. At least in this study, it was a substantially higher. So self-directed perfectionism had a heritability of about 0.25, whereas socially it was about 0.4 or 40%. And there was slightly higher rates in women for both of them, but that was just a point or two. So shared genetic heritage is the same. The other, and this is sweeping with a broad brush, but if we lump parenting into three broad categories, and there are variations, and even a parent solidly in one category may occasionally display patterns in the other. So the three parenting types would be authoritative. So authoritative sets clear limits, guidelines, and enforces them. Authoritarian sets arbitrary rules and limits and enforces them harshly. And lax or negligent just doesn't put any limits on the kids. So we know that both the likelihood of the severity of ADHD symptoms and the likelihood of developing a perfectionistic tendency is higher for harshly critical, again, the authoritarian. There may also be higher rates of ADHD with negligent parenting as opposed to authoritative. So there are commonalities in the parenting or environmental realm. There's also some speculation, and it's hard to test empirically, that because people with ADHD are more prone to making mistakes, or at least mistakes or errors by social standards, because their brains are neurodivergent, they're not following the typical patterns, that may cause individuals with ADHD to be the subject of much more criticism, all other things being equal. And that for some people with ADHD, the perfectionism may be either an attempt to address either their internal criticism, that I have to do better to please these people, or more directly trying to please these other people because you were criticized if you don't. So for some, perfectionism may be is a maladaptive mechanism, or partly maladaptive at least. So, and then again, I'm happy to expound on it here. It's Russell Ramsey, who's one of the leaders of cognitive behavioral therapy treatment for ADHD, and his surveys and CBT focuses on what inaccurate thoughts or cognitive errors are you displaying that are leading to your psychological distress. And with ADHD or impairment, it was perfectionism was at the top of the list, and it was particularly needing everything to be right and lined up before you could go ahead and do anything. And that was a major contributor to starting activities. And it's actually one that in some cases, if we are not careful and we're sloppy about how we explain things, that actually even a neurodivergent sort of approach can encourage the idea your brain is different. Therefore, you need all distraction to be cleared away. You need X, Y, or Z to be lined up and working. You need to be well rested. You need to have all these other things working perfectly, or you're not going to perform at all. And what Ramsey and others' work has shown is, yes, people with ADHD may be more at a disadvantage when they're tired. They may be more at a disadvantage when there's sound or visual distractions. They can still perform. And the best way of ensuring that you'll have a good performance is starting a performance. You can't, if you never start, then you have nothing to turn in, nothing to show for it. And very often, even if you're feeling lousy, out of sorts, that things aren't working optimally, sometimes even if you go ahead, it will feel that way all throughout whatever you're working on. And many times, once you get, if you're able to get engaged and started and working, then you'll become more focused and functional and productive on the task you're trying to do. So Goosebumps is following up and saying they got diagnosed last year. Also convinced that their sister has ADHD. She's struggled with life, keeping jobs and depression, but she keeps resisting going to therapy. Any tips you can, so asking for how do you get someone into therapy who clearly seems to be having problems and has resisted the notion? I'd say one of the best advertisements is, particularly if you have any similar symptoms, to say, I have this. It looks to me, and I would be careful because it may be they experience it different or don't want to be aligned with you or see it the same way. But it looks, I had trouble being on time all the time. It looks like you have that trouble often. For me, what helped was being on Adderall and seeing this doctor who also had cognitive behavioral approaches and taught me to focus on expected time of departure, not expected time of arrival, and other ADHD tools for time management. Um, so one tip is sort of using yourself to advertise how it helped you and making it personal. And again, if there's overlap in symptoms, and again, particularly if there's a genetic connection, that does increase the likelihood that what worked for you may well work for this other person. Second general approach would be to sort of strongly lean into identifying from the outside, I am seeing X, Y, and Z are not working with your life. You've kept losing different jobs, even though you're a smart person. You keep losing relationships, even though you're a nice person. Identifying the problems as you see them, if you're able to say that, and just listening to, and yet I hear that therapy doesn't seem like it has any value or interest to you. That there's a disconnect there for me. So not telling them they're stupid, telling them they're wrong, telling them they need to or they should, but saying, I see this problem from the outside. To me, that's a problem that this type of expertise can help solve. What's in your way in making that connection, and then listening to what they say and responding to what and some of it may be reality based. They might say, well, there's lots of quacks out there. If they say that, I would actually agree. I would say, yes, there are. And there's also a vast body of rigorously done scientific information as to what helps and what doesn't help. And there are a number of researchers or clinicians practitioners, therapists, psychologists, psychiatrists, social workers, who practice according to what has been found to be so and have techniques. Or the person might say they tried it at some earlier point in life. And I would point out that many times, many of these approaches need multiple attempts, and or that the brain is growing and differentiating from an early age to a later age. So what didn't work before doesn't guarantee it won't work again. And again, listening to what their objections are and trying to, if they make sense, actually agreeing. The more you agree with them or acknowledge that that makes sense, and there might be other additional information, the more likely you are to get farther or along the path than if you don't even acknowledge it, but just argue the other side. If you just argue, well, some people get help, or yeah, these medicines work, without acknowledging for some they don't, or then you have much less buy-in. You're sort of, as I sort of discuss it in therapy, you're holding different ends of the stick. Once one person grasps one end of the stick, that forces the other person to the other end, and usually there's ambivalence that both people feel and are aware of, and the more you can identify and align with that, the more likely you are to help someone move towards accepting the view that they are resisting so far. So I'm happy to talk more about that because I think it's an important one. It's part of why I wrote my book, was just to make more people aware of ADHD who might not normally have read a book on mental health. That's part of why I dragged Trump into that conversation. So hello again, James Alexander. His question is, for those who are solidly in the overweight BMI category, such as a 200-pound guy who's of average height, the milligram per kilogram calculations for dosing non-stimulants like the alpha agonists and antidepressants put their target dose above the maximum recommended dose. Should these people be concerned that non-stimulants like the alpha agonists and antidepressants won't work for them at all, poorly, but would work for them better if they were lighter? If so, would it be a good idea for them to drop that weight before taking medications if their ADHD isn't an urgent concern? So there's sort of a twist going in a different direction than I thought. So one is, I would strongly support people who are clearly overweight to lose weight, because it's not just detrimental to their physical health, their knee joints, their heart, but that we know the more excess adipose fat tissue you have, the more likely you are to be in hyperinflammatory states, and that's not good for the brain or the body. Are there some overweight people who live to be 100? Are there Santa Clauses who are happy and cheery all the time? Yes, but there is a strong correlation between overweight and mental health conditions. So I think it's good to be advising people to lose weight or help them with weight if they're overweight. And for the last 20 or 30 years plus, the rate of obesity is higher among those with ADHD than the general population. I won't go into reasons why, but we can if someone wants to. But getting back to the beginning of the discussion is, so I have a separate video on high dose stimulants, and I think there's way too much emphasis on how many milligrams rather than paying attention to what effect is this having on the individual's body, both in terms of good effects and in terms of side effects. That's the reason you're taking the drug. You're not taking the drug to hit the FDA's recommended dosage range or the manufacturers or 4.2 thinks. You are taking the medication for symptomatic reduction. So that's what you should be looking at, and you should be paying attention to the known potential side effects and hopefully finding a dosage that's giving you benefits without side effects. Or if you are having substantial side effects, then that drug may not be a good choice for you. So second, overall, though there are some recommendations based on height and weight and size, in general, for most of our psych meds, and lithium may be one exception, which is kidney excreted, the correlation between body size and effective dosages is really weak and tenuous. I'm not saying it's not there. And sort of embedded in James' question, or I'm reframing it a different way, is should we really be thinking about dosing for, and there's some fancy medical term, overall actual weight, or should we be targeting lean muscle mass weight? And again, I don't know that either are going to be terribly relevant, because it's the brain that's the target organ here. So I can say more on different aspects of that, but I would not worry too much about what the maximum recommended doses are, either derived from weight or derived from other scales. I would focus on what it's doing for the individual. And presumably, if you're not having overt side effects, then most of the hidden side effects, such as elevated blood pressure, which you certainly can check and should be, those are not likely to be a problem, or if you're not seeing lots of visible side effects. So Anthony Howell says, I tried twice to go off my antidepressant medication and found the hard way I needed them. I feel like a slave to my medication. Can you provide some encouragement for those who may feel like me? So two different big issues there. One is just withdrawal issues, or separating out withdrawal from needing the medication. And two is chronic versus acute conditions. So I'll sort of address the second point later. From all the evidence we've had, and this goes back to centuries of looking at people with depression before we had any medications, for most people, depression tends to be a chronic, and both chronic and episodic. So most episodes of depression last for months to a few years, and then most people, even before we had active treatments, got over or through it or around it, and were in a period free of depression for some period of time, but then most of them would fall back into it. And by the time you've had 3 discrete episodes of depression lasting a few months each, you are 90% likely to have another depressive episode. So at least some substantial proportion of people with we're talking depression here, with depression do have a chronic relapsing, remitting condition. And getting back to, I was comparing things to mental health conditions to diabetes. We don't berate someone with diabetes for saying, hey, you took insulin for 10 years. Why are you still taking insulin? You should get off that stuff. It's addictive. Again, the fact that many people need to continue taking it is not evidence that, I mean, it may reflect of course, the underlying condition. And again, there's people like Moncrieff, the first question today, who claim that taking these medications, again, the claim is these are weak medications. They don't really do anything good. They can't do, they're ineffective, but yet they cause problems like withdrawal, and they cause problems like making people, whether you call it addiction or needing to be on it, that they induce depression. The fact that they could be so powerful to induce depression and they couldn't treat it, I mean, certainly it's possible, just doesn't strike me as particularly likely. And the evidence that being on antidepressants actually encourages longer-term depression, I have not seen any convincing studies that come to that conclusion, although many people are claiming they do, or claiming that reasoning. So that's one aspect of it. So the best way there is say, if it's true, and I'll get to the first part of the question, if you really need to be on it, then great. You did your homework, you tried to get off, you showed to yourself, hey, my brain really is functioning better with this on. I'm glad to live in an era where I have an agent which can help me function better with it. To me, that's a positive. Now, if you're having side effects or problems, there may be dosage adjustments or other medication changes that are going to be good for you. So the first point of the question, though, is also an important one. So there is a difference between a withdrawal symptom versus continuing to need it. So again, I'll do the analogy to diabetes. A diabetic may or may not have much of a withdrawal if they stop an immediate withdrawal or blood pressure medicine. You may not have any withdrawal symptoms other than the appearance of the original condition showing up as being untreated. So your blood pressure may be high. Again, we're not talking, so an example would be a drug like clonidine, and potentially with guanfacine, there's a withdrawal of not just leaving you where your blood pressure was before, but shooting it up really high. Again, much more common with clonidine, quite uncommon with guanfacine. So that would be a specific withdrawal. So the question is, if you tried to get off and it was actually withdrawal symptoms, then the approach would be try it again more slowly and a more gradual taper, and most people can get off. Usually withdrawal symptoms, most characteristically, are showing up 24 to 72 hours after your last dose. That may differ with the half-life of the medication. It may differ with your own biology. On the other hand, usually if it's actual depression recurring, that takes 1 to 2 months after stopping for that to usually reemerge. And what's tricky with antidepressant withdrawal is I'm specifically focusing on SSRI withdrawal here. The commonest things are nausea, headache, feeling lousy, sometimes weird tingling sensations, sort of like having a cold or flu, but without the fever usually. But another subset of withdrawal symptoms are emotional volatility and crying at the drop of the hat, and those overlap strongly with depression. So if someone's feeling that way, they might think, oh my God, I missed 2 doses of the Zoloft, sertraline, and now my depression's back. If you're feeling it that quickly and it's mostly emotional volatility and easy crying, that's probably a withdrawal and not a demonstration that you actually need to be on it at this time. And again, usually going back and doing a much more gradual taper, and usually I recommend a minimum of 2 months for everyone who's been on the medication for 6 months or longer. People who are just starting and have side effects usually can just stop after a few days abruptly without a problem. So I hope I haven't over-answered that question, but it's a good one. All these have been good questions, but this one has a lot of general applicability and big issues underneath it that may be relevant. So Max is forwarding another question from the Reddit page from Substantial Bunch. Is there too much difference between reading books and listening to audiobooks? I feel audiobooks are better in the long term because they don't damage the eyes. If you poke the audiobook in your eye, it's going to damage. I'm being flippant there. So there are a number of studies looking at what's going on differently in the brain between. So one is, it depends on what are you reading and why you're reading it. If it's just to get a certain amount of information, both sources may be adequate. If it's nonfiction and it may be more subtle or more enjoyment rather than information-based, there may be different. So what we know is that there are word processing regions of the brain and other parts. So reading activates certain parts of the brain in terms of visual areas because you're reading it, and whereas listening is activating auditory centers. But in terms of some of the higher processing, part of it is that when people are reading, they tend to be much more attentive. Now, can you be unfocused and need to reread the same thing 7 times? Yes, but reading itself, if you're actively reading, engages additional parts of the brain that listening doesn't seem to do as avidly or strongly. So that's part of the argument that we're weakening our perceptual, attentional abilities. Or if you are doing something else while you're doing an audiobook, many people think they're good at multitasking, and people, particularly with ADHD, often think they're good at multitasking, and the evidence is overwhelmingly clear. Yes, can you walk and chew gum at the same time? Yes, but most people by the time they're 15 don't need to be thinking about their walking. If you're doing 2 different tasks that require thinking, like listening to music and listening to an audiobook, or watching a movie on your screen while doing something else, you're not multitasking. The evidence is overwhelming. You're flipping back and forth between the 2 tasks, and that's almost always substantially less efficient than focusing and doing one and then focusing and doing the other. The evidence that reading books damages the eyes, I would argue depends a lot on how you are reading and your practices, including the devices and what you are physically doing, how often you take breaks, how often you change your focal field. And there's been a huge increase in myopia, nearsightedness in the last 10, 15 years, particularly among young people. And it's because of screen watching. And I will not say it's reading. I don't think there's any evidence that the amount of reading has gone up dramatically in the last decade or 2, but absolutely focusing short range on the screen. So I wouldn't make the case or try to make the case that it's reading that damages the eyes. It's trying to focus too closely without breaks for sustained periods of time, whether you're reading or just watching a video game or doing something else. So thanks, Max. Max has provided the link to the high dose stimulant video on this channel. Hello, Mr. AKA asks what dosing schedule should be followed to switch from 50 milligrams of fluvoxamine to fluoxetine. Are chances of side effects higher due to half-life differences? So again, since I'm not anyone's doctor here, I can't be making specific recommendations, and there's so many one would be how long. So fluvoxamine, Luvox, these are both SSRIs. They're both primarily doing the same thing. There's And the SSRIs in general are fairly clean and specific drugs. They're not having particularly strong effects on other agents. And the two that Mr. AK is pointing out, fluvoxamine, and which is Luvox in the US, or fluoxetine, which is Prozac, are the two extreme ends. So most of the others, citalopram, just Lexapro, sertraline, and paroxetine in the US, all have a half-life of about a day. Luvox is substantially less than a day, which makes it more prone to withdrawal effects. Fluoxetine and its active metabolite norfluoxetine have half-lives of about 10 days each. So it's hard usually to have a withdrawal reaction from fluoxetine, because even if you stop taking it, there's plenty in your blood. So in terms of specific dosing schedules, so again, part of it depends how long someone's been on that first medication. If it's just a short time, I mean, what I would say is, and I'm not even off the top of my head, I don't know milligram to milligram. I mean, with fluoxetine, Eli Lilly, which manufactured it for years, only made a 20 milligram size, even though Eli Lilly's own data showed that as long as you're willing to wait a month after treatment started, 6 milligrams, 10, 20, 40, 60 all had the same rate of success and help depression to the same extent. Side effects are higher at the bigger doses. So I mean, presumably one switching to an equivalent dose. I don't know with fluvoxamine that is less potent on a milligram per milligram basis. But I would think for most people, you could probably, I mean, if you wanted, you could take a week at a half a dose fluvoxamine and half of your target fluoxetine, and then at the end of the week, stop the short-acting fluvoxamine. And again, withdrawal issues are fairly unlikely to happen if you have a substantial dose of the new one, fluoxetine, Prozac on board. So I don't know if Tom reports that Lexapro obliterates a lot of rumination for him, but it makes ADHD worse because anxiety is what pushed him to complete tasks. So that's a fairly common finding. And for some people, it's the stimulants themselves that reduce anxiety, and while they may help focus or concentration, may help what someone had learned to rely upon to motivate them to complete tasks. Yeah, so James Alexander is asking me if what I'm saying, and he's reframing it in a useful, constructive way, so thanks. He's asking whether what I'm saying is, if someone's heavily overweight and you give them 100 milligrams of Strattera or 400 milligrams of Wellbutrin and they're not seeing any effect, is it still likely that they wouldn't see much effect even if they lost a substantial amount of weight and were normal weight? I don't believe we have any hard data research whatsoever on that. But my take on it would be yes, actually, I mean, I think some people would fit in either category. I think there would be some people who at the lower weight would see more of an effect from that same equivalent dose, but I think a substantial number of them would not, even if they lost their weight. That's what my assumption would be. And I can explain my logic again, but that's a good way of summarizing it. And yes, you're right, that's what I would conclude. Again, I would still support them losing the weight, but it's not to get more of an effect from their medication. Max said, getting back to perfectionism, since I mentioned that everyone makes mistakes, what do you think a good apology looks like? And can everything be forgiven? So couple things there. I actually don't usually say everyone makes mistakes because that's so trite. I usually say there's too bad you're not one of the 7 perfect people on the planet, because that usually makes people at least pause and think and stop for a moment and say, oh, I get it. Nobody's perfect. In terms of apology, and I have some of this in one of the older videos, I can't remember which one because I don't have a perfect memory. In terms of ADHD in the workplace and how much to share, and this emphasizes, I think, are there places where letting people know you have ADHD can backfire? Yes, it can. Can it be counterproductive? Can you be stigmatized? Yes, it's possible. At least in the US, you actually have a fair amount of substantial legal protections. Are those perfect? No. Are they potentially being dismantled? Yes. But if you warn people in advance, hey, I have ADHD. So sometimes I may be not, and this is true in social situations, not just professional. Hey, wife, hey, partner, hey, whatever it is. You know I have ADHD. Sometimes I'm just going to be nodding ahead and shaking that because I can do that automatically without really listening to you. And you think I'm listening to you. And then afterwards, you're upset that I didn't. So require me to say, yes, I hear you. And this is what you just said, repeating it back to me or having some other system. So again, if you are proactive, then you've set the grounds for making apologies. So if the next day your coworker said, hey, you were going to email me after the meeting with the specs for that, blah, 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 and you say, absolutely, sorry, Jim, I meant to do that. I was going to do that. This is part of my ADHD. I'm trying to get better at this kind of error or reducing this kind of error, but I'm sorry I made it today, and I'm glad you remembered and made me accountable for it. So an effective apology, one is acknowledging, 2 is, again, using ADHD to explain without using it to, I'm blanking on it's not an excuse, it's an explanation. Whether can everything be forgiven or not? The forgiving, so the other half of it is, you may be completely right, and it might be completely reasonable for them to forgive you, and the forgiving is their part. That's not something you have control over. You can influence it, again, by preparing them ahead of time. You can influence it by educating them about ADHD. You can influence it by being sincere and apologizing and explaining what you're trying to do to make it less likely in the future. But whether they forgive you is in their head. You can't, if you're hung up on whether they forgive you or not, that's really counterproductive because that's not in your control. And yes, there may be consequences for you whether they forgive you or not, but again, that's on them. And another bit of folk wisdom is for the forgiver is that when you forgive someone, you're doing it for you more than for them, so that you are letting go of this and not making it a big issue. So those are my thoughts on that. Good question, Max. Hello again, Wesley. Wesley asks, if stimulant medications make ADHD brains look more normal over time, does that mean the good parts of ADHD might be lost too? It's certainly possible. And again, one of the things I would say is, even for someone who's chronically been on medications, I've seen the stimulants and other ADHD medications be powerfully helpful. I've seen people who weren't able to achieve anything by either societal or their own standards, achieve considerably or alleviate really distressing problems that are chronically there. But even when they're working really well, and I think I'm fairly skilled at helping people adjust dosages and figure out augmenting agents so we get as good as our current medications can allow us, I've never seen an elimination of ADHD symptoms. And again, part of this is that ADHD, I would argue, and some of this maybe is just semantics or what level we're looking at it, is more a wiring issue than a neurochemistry issue. Clearly, they're both going on and involved, but that we're not reversing or switching all of the wiring, but maybe substantial parts of it. So to the extent that traits like creativity or enthusiasm or candor are lost, potentially those could be minimized or less powerful than they were previously. James Alexander asks have I had any patients that resisted an autism diagnosis? If so, why do you think they were resistant to it? So my simple answer is I can say, no, I haven't had any patients resist an autism diagnosis because it's not one I often make. And I do have a video on autism and ADHD. I do think there are many individuals who genuinely have autism. I do think it exists on a spectrum. And I also think that I know that there are many therapists out there who don't know anything about ADHD who tell people who have a host of ADHD symptoms, oh, you're autistic. And then you run down the autistic symptoms and you run down the ADHD symptoms, and they don't have any that are in the Venn diagram of only specific for autism, and they have a bunch that are for ADHD. So I much more often see people who and the other one I see a huge amount of misdiagnosis is social anxiety spectrum. If someone is so focused on social rejection, not fitting in, fear of being treated or thought differently, I would say, and this is, I'm pushing it a little far, but almost the very fact that they are focusing so much on social connection. I mean, part of, again, autism's essence isn't that you're just not, that you're feeling rejected or left out. It's that that the importance of social stimuli is just not registering as important to you, that you're not getting it. It's not that you're feeling deprived of it. I mean, and again, I'm pushing things to the extreme. Certainly there are people with autism who are feeling upset that they're not connecting. But if that's the essence of what makes you think you have an autism diagnosis, I would say you should question the diagnosis. So asking the hypothetical, why would someone resistant to it? I mean, one is people are resistant to any people are resistant to any diagnosis. We're seeing a whole flood of, when did Joe Biden know that he had prostate cancer? I think some of the commentary from individuals on the right, I mean, other than being crude, insensitive, non-caring, and general being assholes about it, is just incredibly stupid. They really think Biden hid his diagnosis of prostate cancer, which means he was aware that he had prostate cancer and did nothing to treat it to prevent it from becoming malignant in stage 9. That just is incredibly unbelievable that he would do that. So it's far more likely either it's really fast going and a year ago levels of prostate, or they didn't do prostate tests frequently enough. But to claim that he must have had it because it's so advanced now when it was discovered, you're actually making the case that he had it, he knew about it, and didn't do anything about it till he got life-threateningly sick from it. It's hard to believe they really think he's that stupid or his doctors are that stupid, but that's actually the base. Anyway, so people resist. People don't like to be infirm. People don't like to have bodies that are defective. I mean, and particularly mental illness, there's additional levels of stigma. So people don't like being told that they're different or weird or neurodivergent. I mean, some accept it, but there's a general resistance to it. Is there more specifically? Again, I think part of it is again, as with ADHD, there's sort of this popularized version, which in some ways trivializes it, in some ways degrades it, in some ways distorts it. So again, that would add, in my mind, even though many of those people are well-intentioned, that would increase the resistance. I don't want to be part of that. I don't want to be identified with that. So Mr. AKA, again, I don't want to go too closely into direct advice. So is asking, so this is a question about switching from the short-acting SSRI to a longer-acting, and during the transition period, would sublingual Ativan be appropriate? So Ativan's a benzodiazepine. It certainly helps many people with anxiety quickly. It certainly is a substance most people, unlike the SSRIs, become tolerant to. It's something that some people become addicted to. And part of its addictive potential is everyone has a withdrawal when a dose of a benzodiazepine leaves, and taking another one helps with the withdrawal and helps with the anxiety that was there to begin with. So it could be helpful. My general advice is an Ativan in the pocket is often more helpful, or as helpful as one in the mouth. The other point in the Ativan is one drug that's absorbed more readily if you stick it under your tongue. So it goes into your body more quickly than if you just swallow it. So in general sense, is that likely to be helpful? Is it likely? Yes. Is it likely to be helpful knowing that you have it, and with whether or not you even take it? Yes. So Max, thanks for bringing up the link to the accommodations for school and work. And I don't know why that prompted me, or right at the hour mark. I don't know if I made a repeat. I don't think I did. So on the 29th of this month, May, the Manhattan ADHD group, they have a monthly online meeting where they bring in usually well-respected and prominent ADHD researchers. I'm not, I would say, a researcher, to talk on various topics. So I will be talking about personality disorders and ADHD on Thursday the 29th. That's going to be at 6 o'clock East Coast time. It's on Zoom. I think if you go to the Manhattan ADHD group, they will give you the link for that Zoom. And I think Max or I will provide it somewhere on my site here, or maybe I'll send out a email. James Alexander asks, how can you and your patients tell whether non-stimulant medications are working for them given their more subtle effects? So one is when medications like, so we make a distinction between stimulants and non-stimulants, and I have a video on whether Ritalin methylphenidate, which is the mainstay for treatment in kids, and I would say maybe even worldwide, the difference between the magnitude of effects between Adderall, amphetamine products, and methylphenidate, that difference is bigger than methylphenidate and Wellbutrin, duloxetine, Strattera. So those are all clustered here. What I would say, the real stimulant, Adderall, amphetamine, is up there. And again, unlike what many of the experts say, I do think guanfacine takes us a long time. So two things we're talking about. When we're talking subtle effects, we're talking how big are the effects, and we're talking about how quickly are the effects, because both lead to subtlety. Guanfacine, I've had a few individuals who felt they had a robust response very quickly. Most of the research, most of our thinking on the mechanisms suggests guanfacine is a gradual process, and it takes several weeks to show an effect. In terms of magnitude of the effects, again, but most of the other non-stimulants, so bupropion, Strattera, modafinil, Qelbree, all of these are having fairly dramatic effects on norepinephrine or dopamine availability within minutes to hours. We would expect them to have a quick effect at that given dose. And what I see clinically in patient after patient is they know within a few hours what this drug is doing for their ADHD. So that, again, so in terms of subtlety, we're talking about the time and magnitude. Again, do many people get a more substantial benefit or feel they do from amphetamine than from these others. Many do, but usually if they are going to help, again, guanfacine is one exception in terms of helping gradually, but the others usually the first day you take it, and almost certainly within 2-3 days, you have a pretty good picture of what that dose of the non-stimulant is going to do for you. And if you're not seeing much, my general plan, again, check with your own doctor, treatment team, would be to increase the dose. If you are not having side effects and if you're not seeing enough benefit, you go up pretty quickly. Thanks, Max, for providing the link to autism and ADHD. I know it's a little after 11 East Coast time, but I'll try to run through these because I don't have to go anywhere immediately right now. So Laura Lust asks, would perfection and ADHD have any connection to areas of the brain in a way that is divergent from a neurotypical brain? I don't know. It's a simple answer. It's a good question. I just don't know how much. I mean, there's some evidence that the prefrontal cortical circuits are involved in both. I think there's been more work on ADHD than perfectionism, so I can't say more there. Yeah, so Laura asks, I mean, I have a video about, and it's something like, do stimulants harm your brain? So I flipped it around, but yes, I spoke at a CHAD and ADHD counselor meeting last year on the topic of stimulants are associated with more normalization of brains than kids with ADHD who are not taking stimulants through childhood. So does that mean they're good for everyone? No, but it sort of does flip on its head. The fear that, oh my God, these are evil drugs that are going to rot my brain. It's suggesting we are consigning some kids to worse ADHD over their lifetime by not treating them in childhood. So thanks, Max. So Max provided the link. It's in the chat for the Manhattan Adult ADHD Support Group, May 29th lecture. It's a Zoom meeting, and the link is there. Yeah, so the answer, so James Alexander is asking a follow-up on if people who are massively overweight lose a lot of weight and they weren't responding to the high dose of the drug before, why would I expect some of them still not to respond even though they've lost weight? And why would I expect a divergence, some go the other way? One is, my assumption is that some of those who are not responding to begin with, their lack of response is primarily has nothing to do with their adipose tissue or the greater dilution or distribution of the drug in their body. It's primarily due to their liver enzymes or their absorption or their blood-brain barrier or other catabolic enzymes that are either promoting or increasing how your drug is processing the blood, or the drug, how your body is processing the drug, rather than, again, the volume. It's, again, body weight for most drugs has not been a particularly strong correlation. I mean, maybe the best example here, and this isn't fat, but for many drugs in ADHD, the doses for kids are not that different from adults, even though the body size of adults is 4 or 5 times bigger. Why is that? One simple factor is kids tend to have much more rapid metabolic rates. Or if you compare dogs or rats to humans, again, so metabolic, how your body handles a drug, is the volume of body fat and fluid that it's distributed in one factor? Absolutely. But it's, for most people, probably not the most substantial one. So that's why I say I would expect that most people who are on a big dose. So maybe saying it on another way, even someone who's really large is likely to getting some of that drug, enough of that drug substantially into your brain and onto the receptors where it's needed, even if they're large. And if they're not showing any response, I'd say, again, some of it might be due to their weight, and some of it is more likely to due to pharmacokinetic factors separate from their weight regarding how their body processes drugs. I don't know if that explained it any better. So Laura Lust has another question. Would we see a faster response to bupropion in someone with ADHD in treating inattentive symptoms versus someone without ADHD? I'm not actually, question, let me read it. Would we see a faster response to bupropion in someone with ADHD in treating inattentive symptoms versus someone without? I mean, if they have inattentive symptoms, they have ADHD. I'm not clear whether it's comparing someone with only inattentive symptoms to someone, or if we're asking about the antidepressant. I'm just confused. Sorry. So Max is putting in a blurb for the Reddit page. So Laura, if maybe you're writing it below, and Max also brought in the link for Stimulants May Help Your Brain, which is about more typical looking brain after stimulant treatment. Yeah, so it's yeah, I don't know that speed of response to the medication is going to be that contingent or dependent on whether or not they have inattentive ADD symptoms or not. So that's where I'll leave that. So thanks for all the good questions. Thanks for the engagement. I hope my responses made some sense, and if they don't, I'm happy to return to them and try to clarify my thinking further. I'll be back next week. I'm not even sure where. I'll be in California next week. So thanks for being here. And again, Thursday of next week is that talk at the Manhattan ADHD group. So be healthy, be happy, and I'll be back in a week. And I can't click.